All right, so this session here is really kind of the most comprehensive of all of the falls prevention webinars we're going to be doing this month. It really has a little bit of everything, covers a bunch of topics. First half of it, we're covering statistics, and then into the second half, we're going to get more into the nitty gritty of it. So we'll go to that first slide. So some of the statistics right off the top. Falls remain the leading cause of injury-related hospitalization among Canadian seniors. So it's estimated that 20 to 30% of seniors fall each year. And for the research and the statistics in this case, a senior is considered someone 65 and older. I know our classes, we go 55 and older, but for this particular presentation and the statistics that we have, it's 65. Falls are the direct cause of 95% of all hip fractures and lead to death in 20% of those cases. That doesn't mean that you fall and fracture your hip and you may die right away immediately. It could be kind of starting the ball rolling where you just go on a decline. So in some cases, some people will fracture their hip. They'll end up in the hospital and they can get ill or decondition from there and end up ultimately passing away as a result of the fall that was the catalyst for that. Falls also act as a catalyst for the transition to long-term care. So over 1/3 of seniors who are hospitalized for a fall end up being discharged to long-term care. When we look at where they came from to begin with, that's almost double the proportion of people who are living in long-term care when they fell. So of that 1/3 of people that are discharged to long-term care, only about half of them started there. So the other half came from their own homes or the community. Self-reported injuries due to falls are increasing. So the statistics that we have, they're a little old, but they're done based on a meta-analysis. So it takes time for that information to come through. But based on our stats that we see, 43% increase between 2003 and 2009 and 10. So this information came from the Public Health Agency of Canada. They have a fantastic report. If you did want to dive deeper, that I have the link at the end of this presentation. Seniors hospitalized for a fall on average remain in the hospital 9 days longer than those hospitalized for any other cause. Now, that average often depends on the age. So generally, a younger senior may be on the shorter end of that, whereas someone older, say into their 90s, they're in hospital usually longer than that extra 9 days. And then the number of deaths due to falls are increasing right now. So I think it's a 63% increase we've seen from 2003 to 2008. However, we also need to take into consideration that the age of our population overall is increasing. And I'll just also briefly touch on deaths due to falls typically increase with age. So someone who falls in their 70s is less likely to die as a result of that fall than someone in their 80s or 90s. It increases as you go up the age groups. Number of deaths due to falls are higher in females. But once we standardize for age and sex, males are actually more likely to die as a result of the fall. And each successive age group, as we go up, looking in 5-year groupings, the rate of mortality is approximately twice that of the age group before them. So someone in the 75 to 79 age category is about twice as likely to die as a result of a fall as someone in the 70 to 74 age category. That's just kind of the gruesome details that we're not going to talk too much more about, but I did just want to touch on that. So falls can lead to negative health outcomes such as fear of falling, loss of autonomy, greater isolation, confusion, immobilization, and depression. So what does the research show us when it comes to fall-related injuries and hospitalizations? We're going to go through some graphs here pretty quickly. We won't spend a lot of time. So this first graph here that we're looking at is the incidence of fall-related injuries based on self-report. So that 43% I mentioned before between 2003 and 2009 and 10. This just shows the numbers there. These are self-reports. Moving on to the next one, we're looking at not only the increase in rates of self-reported injuries due to falls, but shows the difference based on sex. So females can be shown with the blue bars, males with the green there. So you can see the significantly higher rates among females. But if you take a look at the most recent two data collections there, in 2005 and 2009 and 10, males had a significant jump in their percentage there, an 11.4% jump compared to 5.7 for females. So males are catching up there. This here, females have an increased rate of fall-related hospitalizations relative to males as age increases. So females in the green this time, males in the blue. Let me switch that up. These aren't our graphs. These are taken from that report. One main factor in this could be because females are at a greater risk of osteoporosis. So there is a greater risk of fractures. So they're more likely to show up at the hospital with an injury. And then there's also a greater proportion of females in the population. And then we're looking at the overall estimated rates of injuries resulting from a fall as age increases. You just notice there's a pretty steep increase there from the 80 to 84 and the 85 to 89 range. So this is just the number per 1,000 people who get injuries from a fall. Again, we're going through that part pretty quickly because that's not fun and interesting. It's more just statistics. So now we're going to go into what causes a fall. So what were people doing when they experienced a fall? And more than any other activity, this chunk right here is walking on any surface other than ice or snow. So it could be walking through your house. It could be walking in a parking lot, anywhere other than ice or snow or stairs. And the next most prevalent spot someone fell was when they were walking on ice or snow. If you want to learn more about that, tune in on November 23rd. We're going to talk about some tips for walking safely in the winter. And then the third most common area someone fell was walking up or down stairs, with 13% of falls happening in that scenario. We move on to the exact location of the falls. As you can see, half of all the falls happened at home. 50% of falls happen at home. Further in this presentation, we're going to go into some tips for making your home safe, but November 14th at 1 o'clock, and we're going to replay it on the 16th at 1 o'clock, a deep dive with an occupational therapist on those tips. The second highest was unspecified, and then the third highest was in a residential institution. So we're looking at long-term cares, things like that. And then what types of injuries are most common? The number one most common area to injure is broken or fractured bones. Well, it's a type of injury. Sorry, I'm ahead of myself. And then the second is, sorry, let's fix my page. Sprain or strain, followed by scrapes, bruises, and blisters. So broken or fractured bones is the most common there. Now we're moving on to body parts. I was talking about this earlier in my falls prevention for bodies in balance class, so it's right in my mind. The shoulder or the upper arm is the most commonly injured area when someone falls, and this is likely because when you fall, you outstretch your arm and try and break that fall, and you're going to get a fracture from that impact often, or if you land on it. At the end of the month, the last falls prevention webinar we're going to do is how to fall. So if you're interested in minimizing the risk of that fracture, you can tune in there. We're going to give you some tips and tricks on that. Then the second most commonly injured area is the knee or lower leg, and then the ankle and foot is the third. So the risk factors for falls are actually a combination. So most falls occur to a combination of factors that overwhelm one's ability to maintain or regain their balance. If you're looking at the technical definition, every person has a unique combination of risk factors based on their life circumstances, their health status, their behaviors, economic situations, social supports, and environment. It all comes together. Understanding what puts you at risk is the first and most critical step in terms of reducing your risk of falling or getting injured from a fall. So we're going to dive deeper into that. And this is probably the part most of you are more interested in learning about. There are four categories of risk factors: biological or intrinsic, which is kind of yourself, your body; behavioral, what you do; environmental, so that's your home, that's your community; and then social and economic actually do also play a role, and we will speak about that as well. These risk factors, they do not exist in isolation, so you don't have just a biological risk factor, you don't have just an environmental. They all come together and combine to create your overall risk. We're going to cover first the biological risk factors. There's quite a few of these guys, 6 actually. So the biological risk factors include those pertaining to the human body and are related to the natural aging process, as well as the effects of chronic or acute health conditions. So the first one here is your acute illness. So symptoms of the illness or medications you're taking to treat the illness can increase the risk of falling. So symptoms such as weakness, pain, fever, nausea, or dizziness can all play a role. And if we're looking at a specific example, urinary tract infections were a precipitating factor in 8% of falls that were reported in this particular case. The second one looking into is your balance and your gait impairments. So these result when there are changes to the normal functioning of the systems underlying your postural control, which can involve biomechanical, so how your body moves, sensory and cognitive changes. Changes to these systems can result in specific instabilities that may lead to falls. Studies have found that the variability in one's gait, so the timing of your step, the placement of your foot when you step, is a risk factor for falls. So an example of this would be if at some point in your life you had, let's say, a hip injury or a knee injury, and you started limping and favoring that joint or that side of the body because of that. And that becomes a new part of your gait. So you're now walking differently. Your hips will move in a different way. The timing of your step will be a little bit different. And over time, this can actually be a risk to make you fall. You may not lift your foot as high, so it may catch the ground. Your weight shift might be a little bit different, where you lose your balance due to a change in your center of gravity. So that's just one example. There's a lot of other ones we could go into. We'll move on to the third biological risk factor, which is your chronic conditions and disabilities. So these are conditions like Parkinson's disease, diabetes, arthritis, cardiovascular disease. So going into that, so estimates show that 60% of Parkinson's participants fell at least once in the year leading up to being questioned. If we're thinking of bladder incontinence, bowel incontinence, that's a risk. People are rushing, trying to get to the bathroom, and anytime you rush, you're at a greater risk of falling. I've had many people say that in the middle of the night, they get up having to urinate, and when you get up right from a sleep and you rush, you don't have your balance, your bearings, so you can fall over because of dizziness. Because of that, you could trip in your clothing, things like that. Diabetes can cause neuropathy in your feet, so you're not sensing where your feet are the same. Arthritis can change the way you move. Cardiovascular disease, that can cause lightheadedness, dizziness, you to get out of breath. So all of those conditions can play into a risk for falling. And we're going to come back to each of these and ways you can manage them after we've gone through them all. The next one we go into is cognitive impairments. So we're looking at things like dementia, or even the normal changes that can happen with age. So there is a link between dementia and gait instability. The side effects of medications to manage behavioral problems in people with dementia can increase the risk of falling. And in terms of the age-related cognitive changes, this can affect your balance through delays in switching your attention from an ongoing cognitive task to the task of responding to an unexpected loss of your balance. And the risk of falling for these individuals is 2 to 3 times higher than others. Low vision, obviously, as you'd expect, is a risk factor. So changes to your vision, such as decreases in visual field sensitivity, acuity, contrast sensitivity, and stereopsis. I think that's how you say that, but that's your depth perception, are all associated with aging naturally, but they increase your fall risk. Generally, this will put you at 2.5 times the risk of the rest of the population for falling. It can impede your ability to walk safely and maintain your balance. And seniors are less likely to begin with than young adults to look at a handrail when entering a new environment, and less likely to direct visual attention to changes in a location and obstacles around them. So if you can't see very well and then you're less likely to look at them anyways, that again increases the risk. I'm saying increases risk a lot, sorry. Muscle weakness and reduced physical fitness. So this one was really interesting. It was a combination of about 3 or 4 different societies of orthopedic surgeons that agreed on this, that muscle weakness is the most important risk factor, increasing your risk of a fall by 4 to 5%. So decreases in muscle strength and endurance can leave you unable to prevent a slip, trip, or fall, or slip or trip from turning into a fall, sorry. You know, if you kind of start to stumble, you can often regain your balance without falling down. If your muscles are weak or unstable, you're less likely to regain your balance and more likely to go down. Weakness in the lower extremities has been found to be a risk factor for fall-related hip fractures. So you're more likely to fracture your hip if you have those muscle weaknesses or instabilities through the lower body. All right, behavioral risk factors, moving on. These are the risk factors that are your actions, emotions, or the choices that you make. And this list is a little bit longer. There's actually 9. So the first one is your assistive devices. So they can promote independence and mobility if used properly and safely. Often people delay the use of these. We're talking canes, walkers, things like that, because there's a stigma associated with the use of these. If they do begin using them, we also have to make sure that they're properly maintained, that they fit properly and that they're being used properly. So example, a cane tip can wear out and it won't be able to support you the same. A walker or a wheelchair, the wheels can become loose. It can be too heavy for you. It could be too high or too low, so it has you in an improper position. Number 2 is pretty obvious, and this one is a problem regardless of your age, alcohol use or excessive alcohol use. So if we're looking at adults in the age of 18 plus, 22% of adults seen in the ER had blood alcohol in their system. So it's an issue across all generations, but it can also interact with medications. So if you're only drinking a small amount, you do have to be careful if you're on medications for other conditions, because that 1 drink or those 2 drinks may not be an issue on their own, but in combination with the medication you're on, that can induce, you know, you lose your balance, stumble, things like that. So reducing your alcohol consumption is an important thing there. Number 3, fear of falling. So this one I always like to call, I always use the chicken or the egg analogy. So what came first, the fall or the fear of falling? Because that's just kind of a loop that feeds each other. So a fear of falling can lead to a decrease in physical activity, which then leads to muscle weakness, poor balance, and poor self-related health. 34% of Canadians over the age of 65 report a fear of falling. And then within that, 44% of those report limiting their activities due to the fear. We can reduce this fear of falling through home and community-based exercise and falls prevention programs, which if you're interested and you're not already attending, I happen to know of a great one. 4th is footwear and clothing. So features of footwear can increase the risk of falls. If your soles are too thick, you can trip. If they're too slippery, you can slip. High heels obviously increase the risk, or if you have those heels that are too narrow, that reduces your stability. If we're looking at clothing, you can have clothing that is too loose or too long that can be a trip hazard, or that doesn't let you move properly. And another example, and satin's coming back in now apparently, is slippery fabric can actually increase the likelihood of you slipping off of furniture and can increase a fall. Number 5, the history of falls. So prior falls are one of the strongest predictors of future falls. Research shows that older adults who experience 1 or more falls are 3 times more likely to fall again within the following year compared to those with no fall history. The reason this is considered a behavioral risk is what you do with the information. So it is a risk when one chooses not to seek information on ways to reduce your risk or not to take action on those risks. So by participating, sitting in on this, you're already taking action, which is fantastic. Then we're going to move on to our inadequate diet or hydration. So dehydration and malnutrition can cause physical weakness, fatigue, and frailty. Sorry, I just lost my point. Malnourished adults who presented to the ER were more likely to report falling in the past 6 months. In 2008-2009, an estimated 34% of Canadian seniors and private households were at nutritional risk. So this lies between nutritional health and malnutrition. So not necessarily malnourished, but they weren't eating properly or drinking enough fluid. And we move on to medication. So older adults taking more than 3 to 4 medications seem to be at a higher risk of falls. Systematic reviews of evidence show a strong association between the occurrence of falls and fractures in older people and the use of certain medications, particularly psychotropic drugs, which alter your mood, sedative drugs, which induce a calm, hypnotic drugs, which induce sleep, such as benzodiazepines, antidepressants, and antipsychotics. Meds that cause drowsiness, dizziness, hypotension, Parkinsonian effects, gait disturbances, or visual disturbances all increase the risk of falling. Furthermore, any drug that decreases bone density or increases the risk of bleeding can increase the risk and severity of injury from falling. So older adults who are taking more than 3 to 4 meds, they seem to be at a higher risk of falls than someone taking less than that. And again, we're going to come back to recommendations around medications in a few minutes. The 8th behavioral risk factor is risk-taking behavior. So behavior is considered risk-taking when there's a discrepancy between the risk associated with the activity and the abilities of the individual engaging in that activity. So like you're not going to go try and, walk up on the edge of a fence if your balance is terrible. You want to stick to what you know you can do. Other examples of this for older adults would be behaviors such as climbing ladders, standing up on a chair to reach the top shelf in your kitchen cabinets, paying little attention to what's around you, or if you are someone who requires a cane or a walker, walking without the use of that aid is considered risk-taking behavior. And then the final one here is vitamin D. So taking vitamin D, this is linked to bone and muscle strength. Some recent research has shown that supplementation of vitamin D combined with calcium can reduce the risk of falls. While other research shows that this only reduces falls among individuals with vitamin D deficiency. So I'm not telling you to go take vitamin D here. I'm just telling you what the research has shown. This would be something that I would recommend speaking to your health professional about. I'm not going to tell you to take or stop taking any medications. Then we move on to the third set of risk factors. So social and economic risk factors. Your social networks, as there's an indirect relationship between your social network and falls. So someone who has a very small social network generally has more falls, and vice versa. If you have a very large social network, you generally have fewer falls if we're looking at the trends. And this can cause poor health, isolation, depression, and disabilities, that isolation. A bigger social network or someone who's regularly interacting with other people, they're often more likely to partake in health improving behaviors. So going to exercise classes, eating properly, avoiding health harming behaviors such as smoking, things like that. Studies have found strong relationships between strong family networks and lower falls rates. And there's actually been shown a protective effect of marriage for those over the age of 80. They haven't figured out exactly what's causing that protective effect of marriage, but they have seen that. Having lived in your current residence for more than 5 years is a protective effect, and having proactive coping strategies in response to stress, higher life satisfaction, and engagement in social activities in older age have been found to lower rates of hip fractures due to falls. So this may indicate the risk presented by social isolation. There's still much more research to be done in this, but try and get out there and do things seems to reduce the risk of falls. And then the second part of this risk factor is your socioeconomic status. So there's been an association of low socioeconomic status and risk of falls. Proposed explanations at this point are the associations with poor environment, poor diet, those with have barriers to accessing healthcare, and then lower education and lower health literacy are all things that they've found fall in that category. And that's not necessarily something that you have a lot of control over. We're going to move on to our environmental risk factors. So these are ones that you can often control a bit more. So these are factors associated with the physical environment, such as building design, entrances, outdoor spaces, furniture. And if you join us next week for the sessions, the first one, November 14th at 1 o'clock, and we'll replay it on the Wednesday at 1. An occupational therapist is going to go through the different rooms of your house and ways you can make it safer. So back to what we're talking about, just more of the overall categories of this. Factors in the community are often related to design standards and building codes that may not take the account of older persons into consideration. So examples of this would be poor stair design, inadequate lighting, lack of handrails, lack of curb ramps and rest areas, uneven pavement, or obstacles on the sidewalk. So when you're out and about, that's what we're talking about. Number 2 is the factors in your living environment. Researchers and practitioners often consider hazards in the home the most common environmental risk for falls. So things here include throw rugs, loose, worn, or really deep pile carpets, having electrical cords where you're walking, door transitions or door sills that are raised, cluttered floors, poor lighting, slippery floors, poorly designed bathtubs, toilets, fixtures in the bathroom, no aids installed such as grab bars or handrails. So grab bars are a really important thing in the bathroom to help with your mobility. And then also your pets can be a fall risk. They're getting underfoot. I know my grandma had a dog that's where he wanted to be all the time, was right in front of her feet. And the number of times she almost fell was scary. Moving to a new location may be sufficient to increase fall risk just due to the I can't say that word, unfamiliarity with the space. So in a home you've been in for more than 5 years, you know where everything is, you know where those raised door sills are, things like that. In a new home, you're not necessarily familiar with that. And then here in Canada, especially, the third part of the environmental risk factors is the weather and the climate. So we have to deal with temperature and precipitation, which can lead to wet and icy surfaces. So snow and ice can reduce the traction underfoot, increasing the risk of slipping. Freezing and accumulation of the precipitation can create barriers to safe access to roadways. So having to climb snowbanks to get onto the sidewalk or out onto the road. Risks are exacerbated when we're rushing because of the cold, because we're uncomfortable. So we're more likely to fall at that time. And then when we wear our wet footwear indoors, which if you go to any of our in-person classes, we ask that you bring indoor shoes, because that wetness that's brought in from the outdoor shoes not only leaves a mess, but it increases the risk of a slip and a fall. So we do want to avoid that. Winter weather can also reduce the effect of mobility aids, such as canes or walkers. So cane tips or walker wheels are more likely to slip, being less stable. And tires of wheelchairs or scooters, if you use them for mobility, they can lose traction, or they can get obstructed, jammed up with snow or the little snow banks. So Canada presents its own extra challenge when it comes to falls. So the part that's most people probably want to know more about is, how do you take action? How do I take all of this information that I've just learned and reduce my risk of a fall? So the very first step is assessing your risk. So finding out what is a risk, what's in your home, what is like medications, what medical conditions you have. Do I have muscle weaknesses? Look at all of that. And then you're going to take a multifactorial approach. So you're going to change everything that you can in those different areas. If you went to a healthcare practitioner, they may do something like this, where they're going to look at whether you've fallen or not, and then ask a series of questions and let you know whether you're at low, intermediate, or high risk of a fall. So someone at a low risk of a fall, recommendations for them are education on falls prevention and advise physical activity and exercise. That is the biggest thing, is get active, keep moving, keep your muscles strong, work on your balance. Someone at intermediate risk, the goal is secondary prevention to improve a major risk factor. So tailored exercises on balance, gait, and strength, sometimes a referral to a physiotherapist, and then education on falls prevention. And someone at a high risk of a fall is much more multifactorial. So this is where if someone's often had a fall or multiple falls, we often see them in home care, where a physiotherapist or an occupational therapist may go into the home, assess what's going on in their life, and make recommendations based on that. So if you are someone who has had a number of falls, that is something you could look into through the home care, is seeing if you could get an occupational therapist or professional to come to your home and help you work through that. Kind of the three key questions that a professional would look at is, have you fallen in the past year? Do you feel unsteady when you're standing or walking? And do you worry about falling? And when we talk about tailored exercises, we're looking at exercises for balance and leg strength. And evidence shows that challenging balance exercises are the most effective for fall prevention. Yeah. And then if we look at the components of a multifactorial approach for community based setting. So this is for individuals living still out in the community in their own homes, essentially not in a long-term care or care facility, because that becomes a little bit different. This is more of a general overview. Some of these we'll be getting into in more depth than some of the other sessions we're going to be doing. So the first one here is your assistive devices and protective equipment. So we're looking at things like walkers, canes, grab bars, things like that. Appropriate use of these is important for those with gait and balance deficits, and you shouldn't just go buy a walker on your own. You would want someone like an occupational therapist or physiotherapist who's been trained in that to come and measure you and decide what the best devices or equipment would be. There's bathroom equipment, there's the tub transfer benches, tub chairs, toilet seat risers, there's Versa frames which go around your toilet. So a lot of things that can be used, and again we'll cover those in next week's session. In Canada, it's also important to be prepared for winter. So we're looking at anti-slip footwear, so good pair of winter boots with traction. We'll cover that on the 23rd. And like we said earlier, seniors tend to avoid using assistive devices because of the stigma, because they're inconvenient or bulky to carry around. But if that's what's recommended to keep you safe, it's a lot easier to carry that cane or that walker around than it is to go through the full rehab of recovering from a broken hip. Better to be safe than sorry. Then you also want to look into managing any clinical diseases. So any health conditions you may have, so including visual problems, cardiovascular disorders, hypotension. So seeing your health professional about this, because there are things that can be done to decrease the risk of a fall. Low blood pressure, for example, so that hypotension that can induce dizziness. It could even make you faint, lose consciousness, and have a fall. So speak to your doctor about any of those conditions. I don't want to get into telling you what to do because I am not your doctor and I don't know everyone's specific cases. Moving on to the third thing here is education. It's important for implementation and sustained use of fall prevention strategies. So effective programs include opportunities for older adults to access fall prevention resources, such as durable medical equipment and local exercise programs. I know an organization that does that. Community care, we have both of those things. We do have medical equipment available from our loan cupboards, and we have a fantastic exercise program, I like to think. And then also taking specific actions to maintain or improve health and build fall prevention skills. So learning how to use your mobility devices or the safety equipment, learning how to transfer safely from a bathtub. If you need a tub transfer bench, how to use it, or how to safely even step over the edge of a bathtub so that you're at a lower risk of slipping and falling. So learning those steps, being aware of those risks as well. And then we're looking at our environmental modification. So a systematic review and meta-analysis actually demonstrated a 21% reduction in falls across all studies and a 39% reduction among higher risk older adults following environmental modifications. So there are some big changes that can be made and have a big effect when we look at our environment and greatly reduce the number of falls. But here again, we want a healthcare professional, such as an occupational therapist, to perform an environmental assessment for required modifications. So the intervention should include modifications of environmental falls risk identified in the home, and both evaluation of daily activities and intervention to promote safe performance. So for example, they will look at what you do on a daily basis. Even if we think of in the kitchen cooking, where are your dishes kept? Are they kept where you can reach them safely? Or are you having to go up on your tiptoes to reach way up above your head? Are you having to use a stool? Both of those things increase the risk of losing your balance. So you want to take a look at what you do day to day, and make sure you're doing that safely. Then we look at my favorite one, sorry, was exercise programs, but we will get into that. I skipped it. Moving on to the medication review and monitoring. So routine reviews with not only your physician, perhaps a pharmacist, are important that way, but any possible interactions, and adjustments under the supervision of a physician or pharmacist. So never ever go and just stop taking a medication because it's one that can cause dizziness. There's probably a reason that you're on it. But having those regular check-ins at your pharmacy, with your physician, to make sure that the medications you're on are all still needed and that there's no interactions between them that could unnecessarily increase your risk of falling. Sometimes the risk is worth it if you need it for a condition or medical problem you may have. Then nutrition and supplements. So older adults require sufficient protein to maintain strength and adequate hydration. And sometimes nutritional supplements are required. So this is where we get back to making sure that you're eating a proper diet, you're eating enough food, including the proteins, you're drinking enough fluid. Dehydration can lead to dizziness, it can lead to muscle weakness, it can make you really tired. So making sure you're drinking enough water. Many people, regardless of their age, are not getting an adequate intake of fluid. So that's something you want to make sure that you're doing, and that you are eating enough and proper food. So healthy food that will give you energy for your muscles. All right, now going to the exercise programs. So this is one of the most important parts of this approach to falls prevention. So research has demonstrated that exercise is effective for community dwelling older adults in falls prevention. A systematic review developed the following recommendations for exercise-based interventions. So when they looked at a number of different exercise programs and the outcomes that they had on the participants in that program, these were the top 8 things that they found each program needed to have to be the most effective. So exercise must provide a moderate or high challenge to balance. This is where you want to make sure that it's within a safe range for you, but still challenging you. So if you're doing, for example, a standing balance exercise, you do want to challenge yourself, but make sure you have something sturdy nearby to grab onto. So like a handrail or the back of a couch or a countertop. That way, if you do start to lose your balance while you're doing that balance exercise, you can grab on and not fall, rather than doing it out in the middle of your living room where there's nothing to hold on to whatsoever. Exercise must be of a sufficient dose to have an effect. And this is where we're looking at falls prevention. So you do need enough of it for it to reduce your risk of falls. However, that being said, in terms of your overall health, every little bit of exercise helps. More research lately has shown that you don't need to do half an hour of exercise at once to get the benefits of it. If you can even go for a walk for 5 to 10 minutes, go up and down the stairs in your house a couple times, all of that is going to add up and benefit your health. One of the things I recommended for some of my groups that have some older seniors in it is a simple way to add extra movement for strength, can help with your balance, is stand up and sit down out of your chair as many times as you can in a minute. Just for 1 minute, and maybe do that a couple times a day. That's going to add up over time and help increase your leg strength, which in this studies we looked at showed that it was one of the most important things for falls prevention. It'll help with your cardio system a little bit and have some great overall benefits. And then the third thing here is ongoing exercise is necessary. So you don't want to go to an exercise class for a month or two and then stop. That will benefit you maybe for that month or two, but beyond that, it doesn't take long to lose it, unfortunately. We're looking at approximately 72 hours to start losing your fitness without doing any exercise at all. So you want to continue participating in your exercise programs, whether it's going for walks, whether you're attending online classes, in-person classes, keep it up. Doesn't mean you have to go 4 or 5 times a week. A couple times a week, even once a week, is better than nothing. The fourth thing here, fall prevention exercise should be targeted at the general community as well as those at high risk of falls. So in our program, we have some different falls prevention programs or classes, I should say. For example, on Fridays at the YMCA, we run one class, which is falls prevention, and one class which is bodies in balance, targeting different levels of individuals. Jody could tell you more on that as to what each class entails. So look at for a class that's the right level for you. Fall prevention exercises may be undertaken in a group or home-based setting. So it doesn't have to, you don't have to, go here or go there. You can do them in different places. We do have a bodies in balance class that runs on Zoom. So you could do that in your own home. But most of them do happen in person. That allows us to challenge you, see what's going on while you do it so that we can keep you as safe as possible while challenging you as much as possible at the same time. Walking training may be included in addition to balance training, but high risk individuals should not be prescribed brisk walking programs. So